So I'm going to talk about MRI staging specifically for low rectal cancers and the particular considerations that we need to bear in mind when looking at these tumours. So there is a particular problem for low rectal cancers. They make up about a third of all rectal cancers that we see, and that most of those that we see are really at 6 centimetres from the anal verge, and the majority of those do get treated with abdominoperineal excision. I think the issues with the abdominoperineal rates and the heights of tumours is something that needs to be addressed in the context of knowing what the stage of the tumour was when they get operated on. And undoubtedly what we're seeing in these group of patients, certainly up until recently, has been the very high rate of local failure associated with abdominoperineal excision as done in the past. And we have also the added pressure that often patients don't want to have a permanent stoma and will be consulting the clinical teams with a view to avoid that if it's possible. So there are particular issues that imaging and discussion in the MDT can perhaps help towards improving the outcomes for this particular group of patients. Now, the state at the moment, or as was seen in the Mercury study and indeed in other studies, is that when we look at the APE rates and compare them with the low anterior resection patients, what we see is, as you can see here, a difference in the staging of these patients. So generally, what's happening is the more advanced tumours, the T3 and more advanced T4 tumours, are undergoing abdominoperineal excision, and the earlier stage tumours, so predominantly T1, T2 and early T3 tumours, are having the anterior resection. So we can see that generally these are a group of more advanced disease patients, and it's not surprising therefore that the outcomes for these patients when they have an abdominoperineal is worse. And we see that from the Mercury study, we see that in the rates of margin positivity in those patients, and you can see, for example, of the 70 patients with low rectal cancer that underwent abdominoperineal, the R1 rate was 30% compared with 16% if they had a low anterior resection. So that's what we're trying to do by improving the selection of patients and also the operation itself. We want to aim to reduce that 31% down to something much more acceptable, i.e. less than 10% with any luck. So the problem for low rectal cancers is that the margin positivity rates in the past, when we've audited the specimens, and Phil Quirk has done a lot of work on this, he's observed that the positive margins are caused by areas of coning during the dissection in the abdominoperineal, so that the margins of resection formed by a conventional abdominoperineal are actually formed by the muscularis propria. And indeed, in some of these specimens, areas of the muscularis propria can be missing, which means that for an early T3 tumour, the margins are going to be involved because the margins are not formed by anything like the mesorectal fascia, they're formed by the muscularis propria. And therefore, a patient undergoing an abdominoperineal with anything much more than a T2 tumour is at a high risk of a positive margin. And we can see in this example here where we've looked at the specimen, we've done the specimen MRI and histology and photographs of the tissue slices. You can see the problem where on the MRI and on the histology, the margins of the specimen are not formed by this nice envelope of mesorectum, they're formed by the muscle tube. And so it's easy to imagine that if you had a tumour that was into the muscularis propria or beyond at that level, then the margins are going to be involved. So this concept of the muscularis propria forming the margins of the specimen is demonstrated on the specimens as the waist, it would be useful for us on imaging to know where that waist is, at what height from the anal verge we are seeing this effect of coning or of wasting of the rectal cancer specimen. So we did a prospective study looking at the abdominoperineal specimens and mapped those MR examinations of the specimens back onto the in vivo examination to see where we could identify where that wasting occurred. And we did so in relation to the anatomical landmarks that we can identify on the in vivo images, such as the external sphincter, the puborectalis and the levator muscle origin and insertion at the level of the puborectalis. In this study we made the following observations: that the external sphincter could be seen at a height of approximately 34 millimetres from the anal verge in these patients. The puborectalis sling was located at a distance between 19 millimetres and 33 millimetres, and the levator origin to its insertion ranged from 35 millimetres at the insertion to 64 millimetres at its origin. So that gives us an idea of where these anatomical landmarks could be, and we could then look at the measurements on the specimen to see where that wasting was in relation to those. So in terms of the mapping of the specimen to the imaging, what we found was that the surgical waist was consistently at a height between 35 to 42 millimetres above the anal verge in all the patients. This corresponded to the top of the puborectalis sling. So in a sense, what we can do is, if we can identify those patients with the tumour at that sort of level, with the invasive portion of the tumour at that sort of level, we can therefore identify those patients that are at the highest risk of ending up with a positive margin due to wasting. And so this point, this level, the top of the puborectalis sling, is the real danger point as far as staging and assessment of rectal cancers go.
I'm sure from an operative point of view, it's also when we evert the specimen, the point, particularly with anterior tumours, where we're most likely to rupture the specimen.
Exactly so, yes.
There's no sphincter wrap at the front, there's just that interface with the prostate.
Yes. So when we're reporting these scans, it's very important, therefore, to relate where the invasive edge of the tumour is in relation to the top of the puborectalis sling, as well as obviously what we also give, which is the height of the tumour from the anal verge. So in the other presentation, you heard about the technique and how it's important to get adequate views and adequate technique in order to show the tumour at its best. And the same, it particularly applies to low rectal cancers. What we do is axial and coronals through the tumour, and it's important to plan these so that you include the relationship of the tumour to the anal canal. So this is the axial imaging, which allows us to see the relationship of the rectal wall to the sphincter complex in the axial plane, and you can see that it's been done so that these scans are planned perpendicular to the long axis of the anal canal. Then the next stack of images are planned coronally, and these are done so that the tumour is seen in the coronal plane in relation to the intersphincteric plane and the long axis of the sphincter and the anal canal. So these are done parallel to the anal canal.
Approximately what number of centimetres above the anal verge do we go from the first set of axial slices, which are at right angles to the anal sphincter, and then you get the horizontal segment, as we call it, which of course is part of our low rectal cancer group, and mostly mid-rectal cancer.
Yes.
So I imagine it must be somewhere about 5 centimetres.
Exactly. I think that's more or less I mean, obviously people's anal canal length varies enormously, but on average 4 or 5 centimetres would be what we'd expect to see to mark off that difference between the top of the anal canal and where the rectum starts to angle backwards, as it were, into the mesorectum. So
and that's longer anal canals in men in general.
Exactly.
Isn't it? Yeah.
Exactly. That's what we observe. And so this is the next series, which, as as you've pointed out, Bill, have to be angled differently because the angle between the rectal wall and the anal canal is somewhere between 90 degrees and 110 degrees, something like that. And so therefore we need to make sure we're perpendicular to the rectal wall on this sequence, so that we can see the distal portion of the tumour for low rectal cancers. And then finally we undertake a set of coronal scans which then allow us to image the lymph nodes within the mesorectum, so that we would like to cover the back of the mesorectum with this coronal plane. So this coronal image essentially shows the challenge that's faced surgically when undertaking surgery for low rectal cancers. And what we can see here is the mesorectal fascia and the TME plane, which takes us down to the surface of the levator here. And I think here is really where the problems start, because you start to see the mesorectum tapering and narrowing down deeper in the pelvis, so that if for example you were to attempt the TME operation and take yourself over the surface of the levator, you are drawn towards this angle here between the levator and the rectal wall where there's tumour coming through. And here, just above the puborectalis sling, as you remember, the danger point is exactly where we would expect to see those perforations that we tend to see with the abdominoperineal excisions performed in conjunction with the TME. So this is something that if we can image beforehand, the surgeon can be warned about, and perhaps they wouldn't then do the TME operation all the way along the surface of the levator. They may stop more laterally and therefore enable the so-called extralevator operation, which takes the surgeon outside this plane and avoids the possibility of entering this dangerous corner by staying outside the levator and then meeting the TME dissection much more laterally than has previously occurred. And this rather simple explanation for the choice between a TME or an extralevator APE really does depend on the location of the tumour, its infiltrating border, and its relationship to this very dangerous angle here between the rectal wall and the levator and puborectalis sling. So the key thing is really getting good visualization of the anatomy, and the technique is really rather crucial in allowing that to happen. And when you do get good quality images, you're able to see the external sphincter complex, the intersphincteric plane, and it matches up very well with the histology sections that we see here on the right. In addition, as you saw with that earlier case, we're able to see the relationship of the levator sling to the puborectalis sling and also the intersphincteric plane very clearly. So it means that we can look at the safety of that TME plane using the coronal images, but of course we need to look at the sagittal and axial images to see the anterior and posterior aspects of that intersphincteric plane as well. So that enables the surgeon to know whether this plane is indeed safe or not for the TME approach. The sagittal images enable us to see the anal verge very well. We can see the columns within the anal canal, and we can see the dentate line, for example, and the distal portion of the anal canal, and therefore give a reasonable assessment of an electronic assessment of the height of the tumour, which complements the digital rectal examination. And I think both do need to be measured. Occasionally there's a disagreement or discrepancy between what we see on imaging and what can be felt clinically. Often these are related to the somewhat polypoidal tumours that can prolapse down and feel lower than they really are, and other times it can be due to the radiologist perhaps over-interpreting some of the edema that you see distal to the tumour and thinking that's still the tumour. So it's very important to... I
think more important clinically have been one or two cases where there have been downward extensions of tongues of tumour, perhaps, that have been missed on radiology, but without any particular effort on his part, the surgeon doing a rectal examination in such a case will pick up any tongues of tumour extending distally. So I think the rectal examination really is very important.
It is important.
And one of the things about low rec is that each of us is separately going to record on our proformas the height we assess as being the lower margin of the tumour.
Right. That's right. It's unusual to find a major discrepancy, I have to say, from all the experience that we have in the MDT, and generally the important aspect, which is the relationship of the tumour to that very crucial landmark, the puborectalis sling. We can come to an agreement about that relationship, and therefore the decision about which plane is safe can be made ahead of the theatre. And that's the big shift in how surgery is planned, because I think in the past these decisions were made when the patient was anaesthetised at the time of surgery, which hopefully will become a thing of the past. I think that hopefully you'll be able to see exactly what you're dealing with ahead of actually going to theatre. So we need to come to some agreement in terms of definitions, and the lower edge of the tumour at less than 6 centimetres from the anal verge will encompass those rectal cancers that are at particular risk of a positive margin. And we find that these are the patients, if there are going to be an abdominoperineal excision, this would encompass pretty much all of the cases that we would see. And therefore, it seems like a good cut-off. Anatomically, it corresponds to the point at which the mesorectum starts to taper, which we see as the site, the origin of the levator muscle. So there is a logic to using this cut-off, because there is an anatomic basis for that height. So the anal verge we can identify looking at the skin change, and we would measure the tumour from its lower border, which generally, for most of the rectal cancer tumours that we see, will have a raised rolled edge, which enables us to see the actual distal margin. And then we would measure the height to the anal verge as if we have a virtual electronic sigmoidoscope. So we would measure straight line. So we'd measure up the anal canal and then the height above that if we're seeing tumour above the puborectalis sling. Now, when assessing rectal cancers and low rectal cancers, it's important to think about the lower third of the rectum at the different points at which the margins could be threatened or involved. And so we've tended to divide the lower third of the rectum into thirds. So there's the segment of the mesorectum that's between the origin of the levator and the top of the puborectalis. There's the segment of the rectum at the level of the puborectalis, and then there's the segment below. So the reason for this is that the potential margins are going to be different depending on those three anatomical levels. Really, between the levator muscle origin and the top of the puborectalis, you can still see a mesorectal fascia, and so potentially those margins are determined by the TME plane. Whereas at the level of the puborectalis, you don't have the fascia anymore, and the margins are really related to what can be removed with regard to the puborectalis itself and the levator insertion. So, for example, in this case, we see a tumour that's had preoperative chemoradiotherapy. The treated tumour is seen posteriorly, and if the surgeon was continuing down in the TME plane, they would obviously be in the space between the edge of the tumour and the puborectalis sling itself, which clearly would result in the risk of perforating the tumour at the back. Now, in most instances, when you have tumour in this position and this location, the sensible thing will be to take the puborectalis and the external sphincter on block without having to get into this plane. And so when you see this at the level of the puborectalis sling, you can make the decision that posteriorly, in a relatively straightforward way, there can be extra tissue removed that would prevent a positive margin for that location of tumour.
As you know, to butt in, I'm passionate about following the nerves down and the anterolateral aspect of that plane, where the levator diverges slightly away from the internal sphincter. That's where, adjacent to the puborectal sling, the neurovascular bundles are particularly vulnerable during an APE operation, and for that matter during an ultra-low anterior resection. But it's strange that we have damaged them more doing abdominoperineals. But that's that key level. Puborectalis is an immediate relation, lateral relation of the converging neurovascular bundles, which I think you're increasingly seeing, aren't you?
We can see them, or we can certainly follow them down as far as the area behind the prostate and the neurovascular bundles there. I think at the level of the puborectalis it is a challenge for us to see them because they're of the order of millimetres, sub-millimetre diameter, so it may be difficult for us to resolve
more
those.
The vessels you'll see,
we'll
because
see the vessels
the nerves have all broken up by then into little ones.
Yes. So I think this specimen illustrates the point that you're making, which is that it's possible to spare those nerves, particularly here where the tumour is all posteriorly. There's no need to take the extra tissue laterally and anteriorly, and therefore you can avoid unnecessary damage if you know exactly where the tumour is extending to and its location. So here we have a posterior tumour. The disease, as you can see on the specimen, is all confined to the posterior rectal wall. So the fact that the muscularis propria is forming the anterior border of the specimen is not a serious problem, because the tumour was never going to be there and there was never going to be a positive margin at this site. So this is really what the potential is in terms of patient gain, is you can start to tailor the planes of your surgery and the radicality of your surgery according to what you know is tumour, and also with bearing in mind that the possibilities that you can preserve organs function and nerve function accordingly. And so this would be an example of how that could be achieved. And then at the sphincter level itself, what we found when we formally measured and looked at the specimens is that suddenly there's a lot more tissue that can be taken, because of course there aren't these structures to worry about, and often you will see quite generous amounts of tissue removed just at the level of the external sphincter itself. And arguably it may or may not be necessary to remove quite that much tissue, and that's another area for development in the future.
Because the less we remove, the less we are forced towards plastic surgeons to fill spaces. So throwing away a lot of ischiorectal fat is one of my particular bête noire, unnecessary. I mean, you never see lymph glands in the ischiorectal fossa, do you?
Exactly. And in this particular case, the tumour has long since finished. Its distal margin was a couple of centimetres higher, and so there wouldn't really be a good reason to take huge amounts of ischiorectal fat out when the tumour is actually finished. So the decision process and the discussions that occur in regard to low rectal cancers are a little bit more complex than what we discuss for mid and upper rectal cancers. We're thinking about the relationship of the tumour to those structures, the puborectalis sling, the external sphincter, the levator muscle. We're also thinking about exactly at what clock position the infiltrating border of the tumour is lying. If it's an anterior infiltrating tumour, then the surgical options really require a much more extensive dissection anteriorly, which may result in for example, the necessity to remove the prostate or a portion of the anterior structures such as the posterior vaginal wall, whereas a posterior tumour, there is much more scope to remove additional tissue. So establishing where the infiltrating border is, where the radial margins are most at risk, will enable surgeons to come to a decision with regard to the particular extension of the surgery that's required to get a clear margin. The other thing is understanding that this conventional T&M staging in rectal cancer doesn't lend itself terribly well for assessment of low rectal cancer. You can see a T4 tumour that's invading the external sphincter that may actually be much more readily operable because you have more space at the level of the sphincter than, for example, a T3 tumour anteriorly abutting the prostate or the urethra. And so the stage itself is rather unhelpful. What we need to think about is the relationship of the tumour to the potential margins that are available to the surgeon for dissection. So in this situation, what we prefer to do is to talk about the relationship of the tumour to the intersphincteric plane and to the rectal wall, because that's a definable plane, and it means if that plane is safe, then the TME plane is safe. And whether you then choose to go down the TME plane and do an ultra-low anterior section, or whether you choose to go down the TME plane and do a Hartmann's or do an intersphincteric APE, are decisions that can be made, but you know that that plane is safe and that there isn't really a necessity to undertake an extra levator, more radical procedure. So this sort of approach would apply to the MRI stage 1 or stage 2 tumours, where on the MR the tumour appears confined to the muscularis propria and does not infiltrate into the intersphincteric plane. And I'll show you an example of that. So here we have a T3 tumour. At the level of the prostate, the tumour is infiltrating anteriorly, but there's a clear millimetre between the anterior invasive edge of the tumour and the mesorectal fascia. The patient was given preoperative chemoradiotherapy because of the proximity to the fascia, and you can see here there's fibrotic stroma that's replaced the tumour signal, and there is now definitely a clear margin anteriorly. But you can see that the TME plane is safe. At the level of the puborectalar sling, the scar was confined to the muscularis propria, and so it is now possible for the surgeon to plan a TME approach surgically, and that's exactly what happened, and the margin was clear of disease. So this is an example of how you can use the pre and post treatment scans to define your planes. Here's an example of a tumour that is infiltrating into the muscularis propria, but again has not got into the intersphincteric plane. So again, you can see here at the level of the distal portion of the levator muscle that the mesorectal margin, the mesorectal fascia over the surface of this, is in fact safe. Anteriorly there is a clear safe plane, and therefore again the TME plane would be safe surgically. However, when we start to see little foci of disease creeping into that intersphincteric plane, that's when we can spot cases where the TME plane isn't safe. And here's an example where the tumour has infiltrated beyond the muscularis propria. So it means that if the surgeon was coming along on the surface of the levator here in the TME operation, there would be a risk of perforating that tumour and resulting in a positive margin.
You use staging there, stage 1, 2, 3.
Yes.
Is that your own staging?
Well, it's one that we felt, rather than confuse things by calling T-stage, we felt that it was better to define it according to the anatomy.
Can you put words to 1, 2, 3, MRI,
yes.
1, 2, 3 in the low rectum?
So in the low rectum, stage 1 is tumour that's not through the muscle coat at all, so essentially it would be equivalent to a T-stage 1. Stage 2 is those tumours that have gone into the muscle coat, so it would be a stage T2, but have not got into the intersphincteric plane. And then stage 3 are those tumours that have got through the muscle coat and are either abutting the intersphincteric plane or actually frankly invading the intersphincteric plane, or lying within a millimetre of the levator muscle, so involving the mesorectal fascia. So those are cases where we would consider the margin to be at risk from the TME approach. And then finally, stage 4 are those tumours that have gone well out into the intersphincteric plane and invading, for example, the external sphincter, or going into an adjacent structure such as the prostate anteriorly or the vaginal wall anteriorly. So they are roughly equivalent to the T staging, but I think it's just a bit clearer, and hopefully would cause less confusion. So here's an example of a stage 4 tumour where there is disease that's gone into the external sphincter. So clearly here the TME approach would result very certainly in a positive margin, and the only safe approach here would be to attempt the more extended operation, i.e. a laterally extended extralevator abdominoperineal excision. And here at the level of the puborectalis sling there is a positive margin because the TME plane has been followed, and that's resulted in perforation of the tumour at this point, which we're seeing on the histology. So these sort of things are entirely avoidable, provided that everyone knows about it ahead of time and the correct plane is chosen. So when we look at the ability of imaging to determine those patients with positive or negative margins, this staging system actually supersedes the traditional assessment of the distance of tumour to the mesorectal fascia, and by adopting this system and identifying the stage 1 and 2 versus 3 and 4, what we then find is that we have picked up the majority of patients with a positive margin. So when you compare the outcomes, if patients are stage 1 or 2, only 3 positive margins were seen in this group, compared with 24 positive margins in patients with stage 3 and 4. And the odds ratio for a positive margin for MRI stage 3 and 4 is 18. So 18 times higher risk of a positive margin. Interestingly, although you see slightly higher rates of margin involvement with an anterior quadrant tumour, or it's not significant, it's not as important as the stage. And so therefore this is the sort of evidence base really for using this kind of staging assessment, and it's independent of whether or not the patient received preoperative treatment. It's even independent of whether or not the patient had an abdominoperineal excision. So this is the key aspect of staging these low rectal cancers.